The integration of transcranial Doppler with head-up tilt test provides a sophisticated window into cerebral autoregulation and the pathophysiology of syncope. While a standard HUT test monitors systemic hemodynamics like heart rate and blood pressure, adding transcranial Doppler allows for the real-time assessment of cerebral blood flow velocity, often revealing changes that precede systemic hypotension. The primary goal of TCD-HUT integration is to differentiate between various types of orthostatic intolerance and to detect cerebral autoregulation failure. Systemic blood pressure is often a lagging indicator. TCD can detect a cerebral precursor to syncope where flow velocity drops despite relatively stable brachial blood pressure. The procedure involves continuous monitoring of the middle cerebral artery using a 2 MHz probe, typically secured with a headband, to ensure a consistent insonation angle during the tilt. Baseline recorded in the supine position for 5 to 10 minutes. Tilt phase. The table is typically tilted to 60 to 70 degrees. Data points. Monitored parameters include peak systolic velocity, end diastolic velocity, and mean flow velocity. Integrating these two tools allows clinicians to categorize the orthostatic response based on cerebral hemodynamics. Vasovagal syncope often shows a progressive decline in end diastolic velocity and a rise in the pulsatility index before the actual faint. Pulsatility index is calculated as Pi is equal to peak systolic velocity minus end diastolic velocity whole divided by mean flow velocity. Orthostatic hypotension, characterized by a parallel drop in both systolic blood pressure and cerebral blood flow velocity immediately upon tilting, indicating a failure of compensatory vasoconstriction. Postural orthostatic tachycardia syndrome (POTS). Patients may show significant oscillations in cerebral blood flow velocity or a modest decrease in the mean flow velocity